Hello and welcome to yet another class at NEET PG Exam. So let's crack NEET PG. So here we are in I am at the platform of Unacademy platform and you are on the platform of Let's Crack NEET PG. So together we will be cracking NEET PG. So welcome to our family. And now about me, myself, I am Dr.Anil Sharma and I am a MD pathologist. Basically, firstly you need to be a member of our family. And how can you be member of our family? Just try to just install our app, Unacademy learning app. Now this Unacademy learning app you can install. After installing, you can subscribe to the plus subscription or iconic subscription. So the plus subscription basically will provide you with live classes, live test, batch courses, structured schedules, okay, and the iconic subscription will probably provide you with the same things, that is live classes, live test. So live classes, which are the gold point, live test and quizzes again are the very gold point, and then you will be provided with prep ladder also, okay. So I don't need to explain about prep ladder. It is one of the better most important app at present for the preparation of PG, and which will be providing you the video lectures, question banks. Now this question bank is well prepared question banks, which again contribution by different teachers, like Dr. Thamim have his contribution, Dr. Apub Mehra has his contributions, and I had collected those questions. So these questions are beautifully collected. Then there is rapid review courses and even handwritten notes which you will get from the prep letter. So this you can be member of our plus subscription or iconic subscription family. But anyway, this is the way you can be our family member. And then the another thing which you need to do is subscription. For the subscription, what you need, you can subscribe for 12 months, 18 months, 24 months and 36 months. And this is iconic subscription. Basically iconic subscription for 12 months or 24 months, those who are doing the final year will help, because nowadays obviously each and every teacher is teaching you according to the practical basis also, so that will help you. So obviously you are paying 55,000 for 12 month subscription, but if you use my code ANLIV, you will be paying 49,000 rupees for 12 month subscription. Now plus subscription you can pay for 1 month, 3 months, 6 months, 12 months. And remember, plus subscription also, if you use my promo code ANLIV, you can get 10% discount. So that is very importantly for you all. You can use my reference code ANILIV, okay. Now coming to the faculty, so here you have one of the very good faculty, that is Dr. Pawan Kandhari. So he is a surgeon and will help you to clear all your concept regarding surgery. Similarly, Dr. Zainab Bora, now she is a gold medalist and she is from AIMS, and obviously she is like I can say she is the one of the most she is well versed and well talented in her topic basis radiology, and whatever she teaches, that thing is sure to be coming in your exam. Similarly, G Rajesh, he is from general medicine, and Dr. Preeti Sharma, so she is an ocean of knowledge in pathology. So basically her way of teaching different special classes is wonderful, and you can just take her classes. And she वैसे ही 7 million watch minutes नहीं होता. Now so we have done about CKD. Basically we talked about CKD, different things we have completed about CKD. So we talked about the pathophysiology, how CKD is occurring, how the impaired glomerular filtration is impaired, okay, and how the fibrosis is occurring, okay. So the fibrosis, which is the main event which occurs in CKD. So this is what we have done till now, and then we have done about uremic syndrome. So now basically, so this is the basic that thing which you have done till now. So in CKD, what happens, whenever there is injury to the kidney, there will be increase in the neuron numbers. As I said, there is increase in the neuron number, and hence there is decrease in the neuron number. What will happen? There will be adaptive mechanism going on. So what will be the adaptive mechanism? Obviously those neurons which are remaining, they will undergo compensatory they will increase in compensatory, that is there will be compensatory hypertrophy, okay. So there will be compensatory hypertrophy. As I said, now आप लोग, अब जैसे मैं हाइपरट्रॉपी बोल रहा हूँ तो ऑब्वियसली यू शुड गो टू योर जनरल पैथोलॉजी. आप अपने जनरल पैथोलॉजी में यू शुड कम go and get reference of what is hypertrophy. So hypertrophy is basically increase in number, increase in mass, okay, not number. So number is hyperplasia. So increase in size basically. So from this size to this size, basically this is known, what is known as hypertrophy. So basically you need to go in your general path and to learn this, that is hypertrophy. Basically for hypertrophy, the mechanism which you learn is in the cardiac muscle hypertrophy. So which of the muscle undergo hypertrophy and which are will go hyperplasia, that you need to know, and just go and read little bit of in your जनरल पैथोलॉजी. सो वो आपको इंटीग्रेट कर देगा, रिवाइज हो जाएगा, ठीक है. सो देयर विल बी एडेप्टिव हाइपरट्रॉपी एंड देन देयर विल बी दैट विल रिजल्ट इन हाइपरफिल्ट्रेशन एट द ग्लोमेरुलस. ओके, सो व्हाट विल बी दिस हाइपरफिल्ट्रेशन विल इंक्रीज ग्लोमेरुलर परमेबिलिटी एंड ऑल्सो इट विल इंक्रीज रैश एक्टिविटी. सो वी हैव ऑलरेडी टोल्ड अवर कि whenever there is hyperfiltration, obviously the renin angiotensin system will be activated, which is present at basically at macula densa. Okay, so now what will this do? This RAS system, this will increase your single nephron, okay, so glomerular filtration rate. So the single nephron glomerular filtration rate will increase, and again that will increase the hyperfiltration of the glomerulus, and this process will go on. And obviously renin angiotensin system, what it will do, it will obviously result in hypertension by activation of angiotensin 1 and angiotensin 2. ओके, सो नाउ व्हाट हैपन व्हेन देयर इज इंक्रीज इन ग्लोमेरुलर फिल्ट्रेशन. तो जब ग्लोमेरुलर फिल्ट्रेशन हाई होगा तो ऑब्वियसली देयर विल बी इंक्रीज फिल्ट्रेशन ऑफ प्रोटीन्स एंड मैक्रोमोलिक्यूल्स. ओके, सो प्रोटीन्स एंड मैक्रोमोलिक्यूल विल इंक्रीज, एंड व्हेन देयर इज इंक्रीज इन प्रोटीन्स दैट इज लाइक एल्बुमिन का ज़्यादा इंक्रीज फिल्ट्रेशन हो जाएगा. सो दैट विल शो एज प्रोटीनूरिया. वी हैव टॉक्ड अबाउट दिस प्रोटीनूरिया आल्सो. सो व्हेन डू यू से इट्स अ प्रोटीनूरिया? सो बेसिकली when do you say it's not a proteinuria? So basically less than 30 to 300 and greater than 300. Okay, so the greater than 300 will be called as proteinuria in case of, and this proteinuria basically it will undergo or it will show dyslipidemia. Now similarly this side, this increased protein, and what they will do, they will act as a nephrotoxic or inflammation. Okay, so the major thing for this major thing which is responsible for CKD or its complication is, what do you say, it is inflammation. Okay, so CKD and is inflammation. So inflammation has the biggest role, or it plays most important role when you are learning about the complication of CKD. So now what happens, this nephrotoxic or inflammatory remodeling, what they will do, they will result into tubulointerstitial fibrosis, and secondary we know very well that there will be glomerulosclerosis or fibrosis. We talked about those. There will be fibrosis is basically the most important manifestation of CKD, which will in long run which happens. So basically this fibrosis, what we will do, it will decrease GFR, it will decrease urine output, and it will result into systemic complication or all those complications and all. So today we'll just go on with systemic complication. So now these are some of the findings which you see in CKD. So you see there will be generalized edema. So general edema, why there will be general edema? Because there will be water retention due to loss of GFR leading to sodium and fluid retention. Okay, there will be sodium and fluid will be retained, and hence there will be water retention, and that will be basically resulting in generalized edema. So what happens, this fluid moves to the extravascular space, because fluid always move from higher vascular concentration to lower concentration. So basically fluid which will be high concentration in the vascular space now will move to the extravascular space due to increased hydrostatic pressure, causing pitting edema in the lower extremities. Okay, so lower extremities, so fluid movements could also be due to hypoalbuminemia in some diseases leading to low oncotic pressure. Now pulmonary crackles, which you will see again another clinical finding which you see in case of CKD. So there will be shortness of breath. Because of this, pulmonary crackles will be presented by shortness of breath clinically. So what happens, obviously there is fluid accumulation which will cause now pulmonary edema, and hence there will be loss of air spaces which will cause ventilation perfusion mismatch, and because of that you will see pulmonary crackles. Okay, so this leaves less area for oxygen diffusion from a blood vessel. As I said, if you are suppose if you are going giving your final year exam and you get a CKD case, so in that obviously you will be asked about the pulmonary. If the patient can present, if the patient is presenting with pulmonary crackles, then you can be asked with the mechanism of pulmonary crackles. Okay, so basically this class which we are taking is will be helping you to clear NEET PG also, and will help you to crack your final year exam also. This is the type of viva question, or this is type of question which can be asked in when you give your final year exam. Okay, and obviously MCQ based question can also be asked. So pulmonary crackles is a finding of CKD or not. Okay, so CKD, when they say you, if they write pulmonary crackles is also finding, you might say कि अरे कैसे होगा pulmonary crackles, तो CKD में नहीं होगा, then you are making mistake. Then another clinical finding is anemia, which will present by fatigue, reduced exercise capacity, and pallor. So how anemia is occurring? So remember, anemia here is occurring with the with loss of erythropoietin. Okay, so erythropoietin, that is the major erythropoiesis stimulator, and this erythropoietin is basically released from kidney. Okay, so with renal failure there will be loss of erythropoietin release. So this is because of anemia. So we'll talk about this anemia subsequently today in our class more detailedly. Down there will be weight loss because there will be and it will be presented by loss of lean body mass, because there will be the patient doesn't feel like eating things. Okay, the patient doesn't feel like eating things. And another, obviously doctor also prescribe less protein diets. Okay, less protein diets, that is another cause. And the third cause is basically energy malnutrition because of metabolic acidosis. Okay, so metabolic acidosis can also result in protein energy malnutrition. So there, because of that also there will be weight loss. So this is about the weight loss. Now today we'll go for systemic complications of CKD. So we have talked about CKD, so we'll do now systemic complication of CKD. So systemic complication, basically there are a lot of complications related to CKD. So when obviously kidney, so when you think about kidney, basically the first thing you think about this okay, the first thing you think about this glomeruli. Okay, first thing you think about glomeruli, and this glomerulus have tubules. Okay, they will have tubule, and then you see that the different electrolytes, they are observed in PCT and also in the DCT. They are secreted in DCT, some electrolytes secreted in DCT. So basically the first thing is, when you talk about kidney, is you think about electrolyte levels and obviously balancing the electrolyte. So the problem there will be with the electrolyte balancing, that is calcium, potassium, magnesium, phosphates. So there will be problem with electrolyte balance. Then there will be problem with acid base balance. If there is problem in electrolyte, there will be problem with acid and base. Okay, there will be problem in acid and base. And there again there will be very importantly associated kidney is, kidney basically we know very well that kidney is responsible for erythropoietin and all, and hence that erythropoietin will result into anemia. And another very important when you talk about kidney is bone integrity. So for kidney we call it renal osteodystrophy. Okay, for kidney we call it renal osteodystrophy. In bone we call it renal osteodystrophy. So this is again important manifestation for in case of CKD, complication of CKD. So let's see complication. So these are the complication in chronic renal failure. So we will have anemia, we will have bone diseases, we will have skin diseases, we will have GIT complications, metabolic complications, endocrinological, muscular, CNS and cardiovascular. So each and every system is affected by this. Okay, and so today we'll just deal with this each and everything individually. So that is our today's class basically. Okay, so now bone diseases. In bone disease, as I said, this will be presenting by renal osteodystrophy. So renal osteodystrophy is bone disease or bone manifest complication of renal CKD. So what will be there? So there will be hyperparathyroidism, osteomalacia, osteoporosis and osteosclerosis. So these are the 4 diseases which you will see in case of bone disease in renal disease CKD. Skin disease, you will see uremic pruritus, eczematous lesion, and cutaneous tarda. So these are the 3 important skin diseases which you see: metabolic, gout, insulin resistance, lipid abnormalities, and hypoglycemia, GIT, GRD, peptic ulcer, pancreatitis, and constipation in CAPD patient. Okay. Then endocrine, you will have hyperprolactinemia, abnormal thyroid hormones, increased luteinizing hormone, decreased testosterone. Okay, this is important. Abnormal GH, growth hormone. CNS, you will have uremic encephalopathy, dialysis associated dementia, aluminium toxicity. Okay, aluminium is used in dialysis, so aluminium toxicity occurs. Then you have seizures, restless leg syndrome, carpal tunnel syndrome, polyneuropathy. And cardiac, basically you have MI, accelerated hypertension, most important. Okay, cardiac failure, coronary calcification, systolic and diastolic dysfunction, uremic pericarditis, and dialysis pericarditis. So these are some of the complications which are associated with CKD. We'll talk about them individually. So firstly, what you are having fluid and electrolyte abnormalities. Okay, so we have already talked about that. There will be derangement of sodium and water handling, and this can be seen at any stage of CKD. Okay, so basically what we have talked about that there will be accumulation of fluid, there will be hypervolemia, which hypervolemia because the fluid will be moving into the extracellular space, and because of that you will be edema will be shown. Okay, because of that edema will be shown. Okay, and then also there can be arterial hypertension. Okay, and then can be the shortness of breath. We have already talked about this, why there will be shortness of breath, why there will be edema, and why there can be arterial hypertension. Okay, that is another. Then another important disease associated with sodium and water is nephronophthisis. Okay, so it is an autosomal recessive disease which is characterized by chronic tubulointerstitial nephritis or obstructive uropathy, and have an impaired ability to concentrate urine. Okay, now hence have symptoms of polyuria. So basically in kidney disease CKD, what you get is you found mostly you get anuria. Okay, you will get anuria. So okay, so you will be getting anuria. Okay, or oliguria, or you will get oliguria. So this will be the finding in case of CKD. But in CKD you can have polyuria also. Now this is only the condition where you will have polyuria. Okay, nephronophthisis. So this is very, very important, hence this becomes important. Nephronophthisis becomes important and point of MCQ, because nephronophthisis, which of the following is true about nephronophthisis? They can ask, and they can say it can be recessive. So option A can be recessive. Okay, option B is basically anuria, option C can be basically oliguria, and option D can be polyuria. Okay, so now you will be confused. So basically normally your concept will say that in nephronophthisis, if it is a chronic CKD, then obviously you will think that CKD will not present by polyuria, and hence you will go towards anuria or oliguria, or you can go towards recessive also. See, basically recessive here it will be not, they will not write recessive. So basically this is dominant, they will write dominant. Okay, dominant. So now the option will be, so it's autosomal recessive disorder, hence basically there will be polyuria. Okay, and defect in urine concentration mechanism. Okay, so when there is defect in the urine concentration mechanism, they will present with hypokalemia. Okay, another important one is potassium derangement. Now this is very much important thing which you see even case of CKD. Okay, in CKD and potassium, these are one of very important things. So the first thing which you need to know is basically in CKD potassium का क्या होता है. So potassium will be mostly showing hyperkalemia. Okay, so in case of CKD potassium, there will be hyperkalemia, that you need to know. Hypokalemia can also present, but more often it presents with hyperkalemia. Okay, so basically see, potassium is what? It is an abundant intracellular cation. Again, now you need to go in your physiology, just see about potassium. The potassium, and when a cell, so a cell will have sodium and potassium is basically inside the cell and sodium is outside the cell, and then there will be obviously the movement of this inside and outside, they will result into what we call it potential. Okay, So basically this is greater than 90% of the total body product intracellularly and less than 2% is extracellularly. So this is the normal in a body, okay, normal in case of the body. Now kidney will excrete 98% of daily potassium intake. So 98% is excreted by the kidney. So in response to increased serum potassium, aldosterone, distal renal tubular sodium delivery and tubular fluid flow. So basically how it excretes, how kidney will excrete sodium with the help of, whenever there is increased potassium, there will be basically what there will be response, like they will increase aldosterone, there will be distal renal sodium delivery will be increasing and tubular blood flow will increase, and in that way it will increase basically excretion of 98% potassium. Okay, in case of CKD and ECRD, there will be potassium derangement and there will be increased risks of adverse cardiovascular event and mortality. We know very well that potassium has a protective phenomenon for cardiovascular events. Okay, so basically whenever there is deranged potassium, there will be adverse effect on cardiovascular events. Coming to the hypercalcemia. So what is this hypercalcemia? It is the most common life-threatening electrolyte disorder in CKD. Okay, so now this itself becomes a MCQ here. Now how do you classify this hypercalcemia? So you can classify them accordingly, that mild, moderate or severe. Okay, so mild are basically where you are ranging from 5.1 to less than 6 millimoles per liter. Moderate is for 6 to 7 and severe is greater than 7 millimoles per liter. So that is giving you hypercalcemia. Okay, so in kidney disease, in CKD patient, you will be getting, most of the time doctor will do electrolyte, and in that most of the time you will get hypercalcemia, you will get hypercalcemia. Okay, so this is important, hyperkalemia. Okay, not semi-kalemia. So now remember one thing, that whenever you get hyperkalemia, so this is for the practice, those if you are practicing or if you are clinician, so you should understand that you should be aware of pseudo hyperkalemia. So you should ask to the pathologist or to the biochemist that whether basically phlebotomy technique was done properly. Okay, so basically if you bind, if you bind and if you are binding for a longer period of time, obviously there are chances that there will be occurring hemolysis, and then that hemolysis can increase hypercalcemia. So kalemia, so potassium can be high in that. Okay, there you should also see CBC finding. If there is thrombocytosis and leukocytosis, then that thrombocytosis and leukocytosis can also result into hyperkalemia. So that you should remember. Okay, so this should be remember before you interpret or actually it is higher or not. You should know that there can be pseudo hyperkalemia, and that can be because wrong faulty phlebotomic technology. Phlebotomy means collection of blood. Okay, and hemolysis in the tube, or thrombocytosis and leukocytosis. Okay, now remember hyperkalemia can also be caused or exacerbated by, so that was about the CKD, but it can be also caused by transcellular shift due to insulin deficiency. Okay, so you know very well, whenever there is insulin deficiency, there will be transcellular shift, and then that can cause hyperkalemia. Mineral metabolic acidosis and tissue breakdowns like hemolysis, rhabdomyolysis, tumor lysis syndrome and tissue ischemia can also result into hyperkalemia. High potassium intake, usually in patient with undergoing CKD. Medication induced defects like in renal potassium excretion, most commonly angiotensin converting enzyme inhibitors, angiotensin receptor blockers, mineral corticoids receptor, or potassium sparing diuretics and calcineurin inhibitors. So they can also result into potassium excretion, defect in potassium excretion. Diabetic CKD patients are also at risk of developing hyperkalemia due to hyporenemic and hypoaldosteronism, that is type 4 renal tubular acidosis. In that cases you can get hyperkalemia. So these are other causes of hyperkalemia. In short, I can say that these are the other causes of hyperkalemia. Now clinical manifestation, you know very well, it will present as non-specific muscle weakness, paresthesis, paralysis and cardiac arrhythmias and cardiac arrest. Okay, so now this is very very important thing you need to know. So now you remember that there is benefit of RAS inhibitors in heart failure, even in acute coronary syndrome, CKD, and in diabetic nephropathy. But hyperkalemia, because of hyperkalemia, you should use this very judiciously, RAS inhibitors, because here we have already seen that obviously the RAS inhibitors, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, mineralocorticoid receptor antagonists, potassium sparing diuretics, they can result into abnormal renal defect. Okay, so because of that, you should use judiciously, because hyperkalemia limits their use in case of CKD patient. Now, and another important thing, cardiac manifestation of hyperkalemia. You all know that hyperkalemia, it reduces the transmembrane potassium gradient, okay, and hence this it will cause multiple electrocardiographic changes, and the most important is peak T waves. Okay, we have talked about, you all know very well from your medicine studies that there will be peak T waves, and whenever there is peak T waves, it is basically hyperkalemia. So peak T wave is basically hyperkalemia. Then prolonged PR interval, okay, and then basically loss of P waves and widening of QRS complex. So this is very important findings in case of ECG findings in case of hyperkalemia, where you get most of the questions, okay, regarding hyperkalemia. So basically another thing important is hypokalemia, which is less common in case of CKD. So because this can be due to gastrointestinal potassium loss from diarrhea or vomiting, or renal potassium loss from non-potassium sparing diuretics. So if you are using non-potassium sparing diuretics, or there is renal or vomiting, then that can cause hypokalemia. Okay, occurs in dialysis patients. So basically hypokalemia is common in dialysis patients. So those patients which is undergoing dialysis, so after dialysis it can be that they can have low potassium due to exposure in dialysis. What they do, they export low potassium dialysate. Okay, so because of exposure of low potassium dialysate, they can hypokalemia can occur in case of dialysis patient. Coming to the metabolic acidosis, this is another complication which you see in CKD. So basically remember that renal tubules, they reabsorb 4500 millimole of filter bicarbonate daily. So basically they are reabsorbing bicarbonate. So bicarbonate is that which will be balancing your acid. Okay, bicarbonate are those which will balance your acid or H plus. So basically one way of metabolic acidosis is there is problem in bicarbonate. Okay, another cause of metabolic acidosis basically is that there will be excess ammonia genesis in case of CKD. In case of CKD, there will be excess ammonia genesis. Okay, so remember 80 milliequivalent of bicarbonate are daily required for neutralization of net acid which is formed in case of urine. Okay, so now whenever there is decline in the kidney function, what happens, there is the capacity of bicarbonate conservation and generation will decrease, and hence this bicarbonate now they can't neutralize the acid. Okay, so basically, but the net endogenous acid production is same, hence it's the bicarbonate which cannot neutralize now the acid, and hence there will be genesis of acidosis. Okay, then again we have already talked about that in CKD there will be reduced number of functioning new nephrons. Now that nephrons, they will undergo basically they will undergo hypertrophy. Okay, the remaining nephrons will undergo hypertrophy, and hence there will be basically the capacity to excrete. So basically those nephrons now they will not be able to excrete the ammonia NH3 in the form of NH4 plus. Okay, so your NH3 will increase, NH4 plus will decrease. Okay, hence because this as I said, there will be undergoing hypertrophy and compensatory generation of large amount of ammonia, but this there will be increase of ammonia. This will activate the complement pathway, so leading to the tubulointerstitial inflammation and injury. Okay, so this anemia will activate the complement pathway, and this complement pathway will result into inflammation and injury. Okay, remember excess acid will increase endothelin 1 and aldosterone production, which will accelerate CKD progression. So this will make a vicious cycle. Okay, anemia increase होगा, tubulointerstitial increase होगा, एसिड बढ़ जाएगा, एसिड बढ़ेगा तो फिर से और एंडोथेलिन 1 बढ़ जाएगा, एल्डोस्टेरोन प्रोडक्शन बढ़ जाएगा, वो फिर CKD करेगा, CKD होगा, फिर से एनीमिया बढ़ेगा, अमोनिया बढ़ेगा, अमोनिया बढ़ेगा, फिर से वो CKD कराएगा. So this will be a vicious cycle. Okay, that you need to know. So metabolic acidosis results in, so what happened because of metabolic acidosis, there will be protein catabolism. Okay, so as I said, there will be weight loss because of metabolic acidosis, because metabolic acidosis results in protein catabolism. There will be muscle wasting, there will be bone demineralization, insulin resistance, impaired thyroid hormone and growth hormone secretion, exacerbation of beta 2 microglobulin accumulation, and there will be increase in mortality. So basically metabolic acidosis will result into CKD plus this all thing will happen, and because of all this thing, other all manifestation of CKD can be seen. Okay, so we have done already hyperkalemia and metabolic acidosis. Now anemia is another important complication you see in case of CKD. Okay, so anemia is another important complication you see in case of CKD. So what happened in anemia is basically most important cause of anemia in case of CKD is insufficient production of endogenous erythropoietin. Okay, so basically kidney is responsible for production of erythropoietin, and basically there is insufficient production of endogenous erythropoietin in case of anemia. Okay, so that you need to remember. Now other causes can be like iron deficiency, acute and chronic inflammatory conditions. Okay, then you have severe hypoparathyroidism, aluminum toxicity, this in case of dialysis. Okay, dialysis, then folate deficiency and decreased survival of RBC and RBC loss. Okay, so that is important. Now remember, another thing you need to remember is pathogenesis. So how anemia is occurring in renal failure? So basically it is because of erythropoietin deficiency. Okay, so now why I am taking again and again about erythropoietin deficiency, because जब आप एनीमिया का बात करते हो तो आयरन डेफिशिएंसी एनीमिया बेसिकली आपका उससे हो जाता है, क्या बोलते हैं, आयरन डेफिशिएंसी से हो जाता है. ठीक है, एक सेकेंड. ओके, देन बेसिकली फॉलेट डिफिशिएंसी की वजह से फॉलेट और विटामिन डिफिशिएंसी का मैक्रोसाइटिक एनीमिया हो सकता है. ठीक है, सो नाउ बट हियर द मेन कॉज ऑफ एनीमिया हियर इज बेसिकली erythropoietin deficiency. रिमेंबर इन्फ्लामेशन, एज आई सेड ऑब्वियसली CKD में क्या हो रहा है, मोस्ट इंपॉर्टेंट इवेंट क्या हो रहा है, इन्फ्लामेशन. सो दिस इन्फ्लामेशन कैन कॉज anemia. Okay, anemia. So anemia of chronic disease, you know very well, you know about one anemia, that is anemia of chronic disease. So ये anemia of chronic disease is mostly occurring because of this inflammation. Okay, so we'll talk about the difference between the anemia in CKD and anemia of chronic disease. So basically there is sustained presence of HIF lead to, so whenever there is basically as I say there is decrease in GFR or there is hypoxia or any kind of condition, what happen, there is sustained products of hypoxia inducing factors. This hypoxia inducing factor will lead to signal transduction and synthesis of erythropoietin. Okay, erythropoietin will be secreted from the kidney whenever there is HIF. So sustained hypoxic, okay, hypoxia inducing factor. So in normal patient, what happen, plasma erythropoietin level increase dramatically in response to anemia. So whenever there is anemia, obviously there will be increase in erythropoietin because of this HIF. Okay, now with CKD, whenever there is kidney failure, erythropoietin it cannot increase. Okay, this erythropoietin cannot increase. Okay, and hence there will be anemia in this patient. Now remember, this is basically your how erythropoiesis occurs. So basically you have a purely protein stem cells which will be forming burst forming unit erythroid cells, colony forming unit erythroid cells. So remember, यहाँ से भी अब मैंने बोला इंटीग्रेट करो. So ये erythropoiesis है, यहाँ से क्वेश्चन आया हुआ है. कैसा क्वेश्चन आया हुआ है, which of the following event ठीक है, which of the following event takes place first in erythropoiesis. Okay, so they gave you the option like BFUE, okay, to CFUE, okay, or 3 your basically pro-erythroblast, और 4 रेटिकुलोब्लास्ट. सो देयर इज दिस फर्स्ट इवेंट कौन सा होता है, प्रीवियस पहले कौन सा होता है. सो जस्ट यू शुड नो दिस pathway very well, it is burst forming unit or erythroid cells. Okay, burst forming unit. So burst forming, they will not give you this burst forming unit, so it is burst forming unit which forms before colony forming unit. So यहाँ तो कोई confusion नहीं होगा, इसमें confusion होगा, ठीक है. So you should remember this. यहाँ से एक question तो इससे ही बन जाता है. Now coming to the basically here, this is basically erythropoiesis का pathway. That's how RBC are formed. Now remember erythropoietin. This erythropoietin is basically, it will increase or it is stimulating your burst forming unit and colony forming unit. Okay, now if there is no erythropoietin, अगर erythropoietin नहीं होता है, suppose erythropoietin is not present, what happens, this burst forming unit and this colony forming unit, they will undergo apoptosis via fast ligand. Okay, so fast ligand will be, so that domain F is fast ligand death. Now again go and revise your apoptosis, which is two pathway, intrinsic pathway and extrinsic pathway. So this death was occurring extrinsic pathway via, so fast ligand or FADD pathway. Okay, so extrinsic pathway of death. So that you need to remember in case of your apoptosis. Okay, so basically now go and see once apoptosis का intrinsic pathway extrinsic pathway पढ़ लो एक बार. intrinsic pathway में basically caspases का activation. Okay, so which are the initiator caspases and the which are the executioner caspases. So उसको पढ़ लो. So basically you that will be integrating your general path again. So आपको अलग से पढ़ने की ज़रूरत नहीं है. Now so फिर ये undergo apoptosis, ये हो गया apoptosis हो गया, ठीक है. सो अगर एरिथ्रोपोइटिन नहीं है तो, ठीक है. सो बेसिकली इन CKD देयर विल बी रिडक्शन ऑफ एरिथ्रोपोइटिन एंड हेंस दिस RBC cannot form and they will undergo apoptosis. Okay, so that is important. So now again what you need to remember is basically so now this is role of erythropoietin alongside erythropoietin. So this happens in your CKD, but in case of chronic disease, in case of chronic disease, what happens, there will be increase of hepcidin. It is hepcidin which is resulting in, see, hepcidin will inhibit erythroblasts. Hepcidin will inhibit erythroblasts and it will result into decreased iron absorption, iron transport and iron availability. So in anemia of chronic disease, it is hepcidin which will increase. Okay, so which of the following happens, which of the following takes place in, which of the following is not true in anemia of chronic disease? They will ask that. Okay, anemia of chronic disease, which of the following is not true in anemia of chronic disease? Okay, so they can just say that reduce hepcidin. One option will be your reduce hepcidin. Okay, they can give you increase, okay, like increase iron content. 3, they can give you TIBC. About TIBC, there can be increase in TIBC. Okay, so basically you need to remember that hepcidin is major cause of anemia of chronic disease, but in anemia in CKD is because of decreased erythropoietin production. Okay, now remember this factor like TNF alpha, interleukin 1, they are the inhibitors of hepcidin, but factors like interleukin 6 and interferon gamma are those factors which promote hepcidin. Okay, so they promote hepcidin. So hepcidin, basically what is hepcidin? Hepcidin is a peptide which is produced by liver that interferes with RBC production by decreasing iron availability for incorporation into erythroblasts. Okay, so hepcidin gene expression is upregulated by IL-6 and iron overload and downregulated by TNF alpha and iron deficiency. The hepcidin basically binds with the ferroportins and the membrane embedded iron exporter and results in internalization and degradation of the complex. So this inhibits iron transport across cell membrane, trapping it into the macrophages and preventing it from being absorbed from the intestine. So in case of anemia of chronic disease, the iron store, that is ferritin, is basically normal. Ferritin is trapped, but okay, and TIBC is again increased because iron is basically trapped in macrophages. So this iron will not be found in blood. ठीक है, so iron क्या हो गया, यहाँ macrophages में trapped हो गया, ये blood है, blood में ये TIBC प्रोटीन होता है, TIBC, ओके, ट्रांसफेरिन बाइंडिंग कॉम्प्लेक्स। सो ये TIBC क्या करेगा, अब ब्लड में जब कम आयरन मिलेगा, इसको कम आयरन मिलेगा तो व्हाट इट विल डू, इट विल इंक्रीज इटसेल्फ, ताकि जितना आयरन मिले थोड़ा मोड़ा भी उसको बाइंड करने की कोशिश करता है, ठीक है। सो बेसिकली TIBC विल बी इंक्रीज बट आयरन स्टोर्स विल बी नॉर्मल इन दिस केस ऑफ एनीमिया ऑफ chronic diseases. Okay, so now how will you treat this? Basically you can give erythropoiesis stimulating agent. Now remember, obviously you can give iron therapy, so learn about iron therapy. So and also you can give erythropoietin stimulating agent. So what you can do, you can give epoetin, you can give darbepoetin. Now these are the drugs, they can be asked, okay. So darbepoetin is the erythropoiesis stimulating agent. So what is the function of darbepoetin, they can ask you. Or there is methoxypolyethylene glycol epoetin beta, okay. So these are different types of drugs used for the treatment of erythropoiesis stimulating agent. Remember, erythropoietin is better to give subcutaneously, okay. It is better to give subcutaneously, it is given subcutaneously, okay. So it is better to give subcutaneously. Another problem is abnormal hemostasis. So later stages of CKD may have prolonged bleeding time. So basically later stage of CKD, this can present with bleeding times, increased bleeding time, decreased activity of platelet factor 3, abnormal platelet aggregation and adhesiveness, and impaired prothrombin consumption, okay. So this can be the problem in case of CKD in later stage. So clinical manifestation will be like there is increase in tendency in the bleeding and bruising, there will be prolonged bleeding from the surgical incisions, there will be menorrhagia, GI bleeding, okay. So the greater susceptibility to thromboembolism, and there is greater susceptibility to thromboembolism. Now this point is important because why? Basically this thromboembolism will occur in the renal diseases with nephrotic range proteinuria, and this will result into hypoalbuminemia and renal loss of anticoagulant factors, okay. So we have talked about this. So how proteinuria will also, there will be loss of protein C and protein S, those which are basically anticoagulant, okay. So basically hence there will be anticoagulant factors will also be lost. This will lead to thrombophilic state, okay. This will lead to thrombophilic stage, and because of that there can be greater susceptibility to thromboembolism, and hence you should judiciously use the drugs like warfarin, heparin, okay. That should be judiciously used. So what is the treatment for this? You can temporarily use desmopressin, okay, cryoprecipitate, or you can use IV conjugated estrogens, you can do blood transfusions, and also you can use erythropoietin therapy, okay. Optimal dialysis will usually correct a prolonged bleeding time, okay. Now remember, unfractionated heparin, normally fractionated heparin is used, but here unfractionated heparin is better than the fractionated heparin, okay. So unfractionated heparin is better than the fractionated heparin in case of hemostatic problems in kidney disease. Now another clinical manifestation or complication of CKD is neuromuscular abnormality. So what happened in neuromuscular abnormality? So this basically we know very well कि central nervous system, peripheral and autonomic neuropathy are very important abnormalities which are seen in case of CKD, okay. So basically in CKD what you see is uremic neuromuscular disease, which basically seen at the stage 3 CKD, okay, uremic neuromuscular disease, okay. Then obviously the early manifestation will be like mild disturbance in memory, concentration and sleep disturbance. The kidney disease patient, they usually can't sleep, they can't concentrate, and the memory, there is mild disturbance in the memory. But later on in the late stages, what you can see hiccups, cramps, you can see twitching becomes evident at later stages. In advanced untreated kidney failure, you can give asterix, myoclonus, seizures and coma can also occur. So these are the neurological manifestation. So these are the early manifestation and these are the late manifestation. So now remember, you can be asked a question, which of the following, so hiccup is so which of the following is early manifestation, which of the following is late manifestation of CKD, okay, late manifestation of CKD. So they can ask you, okay, so memory loss, whenever you see memory disturbance, and you will see okay memory तो जल्दी नहीं होता बोल के, so but see mild disturbance in memory you can see in basically early. Hiccups, so hiccups can be used as one of the, you will say that hiccups, okay hiccups तो जल्दी आ जाएंगे बोल के, so basically hiccups and cramps they are late manifestation, okay, ठीक है, late manifestation. Now peripheral neuropathy, this is another complication, CNS complication which you see. So basically this is seen in stage 4. So now again the question forms, peripheral neuropathy normally stage 4 में दिखता है, but uremic, okay, uremic nephropathy you can see in case of stage 3, okay. So here now again the MCQ बन गया, initially क्या loss होता है. So initially it is sensory knobs which are involved, not the motor, okay, it is sensory knobs which are involved. Now remember this all are important when you case, suppose आप फाइनल ईयर में हो, आप एग्ज़ाम दे रहे हो, आपको CKD का केस मिल गया, ओके. सो बेसिकली यू शुड इन योर हिस्ट्री यू शुड include the neurological examination also, and in neurological examination you should check about whether sensory knobs are working properly or not, then you should check about the motor knobs are working properly or not, okay. So because of CKD there can be chances that there is loss of sensation in your thigh region, in the lower limbs can be seen, or there can be loss of sensation in your upper arm also, okay. So there can be loss of sensation, and the patient might be under treatment, and hence he might not say you anything when you talk about history. लुक इन CKD पेशेंट में हिस्ट्री आपको लगभग, जैसे अब एनीमिया तो पेशेंट बताएगा नहीं आपको, ठीक है, ज़्यादातर फाइंडिंग्स होते हैं हिस्ट्री, जैसे फीवर ऐसे कुछ प्रेजेंटेशन से कुछ कर आता नहीं है पेशेंट. सो व्हेन देयर इज एंड देन व्हेन यू स्टार्ट इट बिकम्स रियली डिफिकल्ट फॉर यू टू आस्क व्हाट इज हैपनिंग इन दैट केस. सो बेसिकली हैंस एग्जामिनेशंस इन केस ऑफ व्हेन यू आर गिविंग अ फाइनल ईयर एग्जाम, आपको सबसे इंपॉर्टेंट चीज़ है आप ये सब चीज़ें भी पूछो पेशेंट को. एंड यू शुड, इफ सपोज अ पेशेंट इज गिविंग आई कैन नॉट मूव माई अपर लिम, पिछले 2 महीने से चला नहीं पा रहा, ओके. सो बेसिकली यू शुड थिंक कि दिस कैन बी अ कॉम्प्लिकेशन ऑफ CKD, ओके. CKD का कॉम्प्लिकेशन भी हो सकता है बोल के, तो यू शुड रूल आउट CKD ऑल्सो in when you are giving your exam or when you are taking history in case of those patients, okay. There can be restless leg syndrome. So restless leg syndrome is basically characterized by ill-defined sensation of some time which is very discomforting in the legs, and hence to remove that discomforting, what you do, you will be frequently moving your legs, okay. You start moving your legs very rigorously, okay. So this is basically seen in peripheral neuropathy in case of CKD, okay. Evidence of peripheral neuropathy without any other cause, like example diabetes. So whenever peripheral neuropathy, you see peripheral neuropathy in a patient, and you have ruled out the diabetic neuropathy history or any other tumor or any trauma or tumor cases or brain pathology, then what should be your another thinking should be that it can be of renal, okay, because of renal. So then about the bones, okay, bones. So renal osteodystrophy. So renal osteodystrophy, basically there is problem with your in renal osteodystrophy there is problem with your phosphates, okay. There is problem with your phosphate, there will be hyperphosphatemia, okay. So CKD patient, they will develop hyperphosphatemia, and this hyperphosphatemia basically will result into all your maximum renal osteodystrophy anomalies, okay. So basically because of renal phosphate excretion, so whenever there is CKD there will be a decrease in renal phosphate excretion, and that renal phosphate का जब excretion कम हो जाएगा, then what happen, obviously there will be decrease in case your serum calcium, and that serum calcium decrease will do, it will increase parathyroid hormone. So we'll talk about that thing again in today's class, that is, so this is not so important for you at present. So remember bone cells, whenever bone cells are forming, so you have active osteoblast cells, so which are basically responsible for formation of collagen, alkaline phosphate, osteocalcin, osteopontin, and bone siloprotein. So these active osteoblasts are forming, remember. And then you have active osteoclast cells, okay, osteoclast cells. So these osteoclast cells, they are forming from homophytic osteoclast progenitors, and remember osteoblast cells they are forming from mesenchymal osteoblast originator cells, okay. This you need to remember, this can be your MCQ. So basically, and remember Suppose this is osteoblast cells. As I said, osteoblast cells coming from your mesenchymal cells, stromal cells. So what they will do, so basically these osteoblast cells, they have a rank ligand which binds to the rank receptors. Okay, rank ligand and rank receptors, and this binding will result in a kappa B pathway activate, and hence there will be differentiation of osteoclast cells. Okay, so this way osteoclast cells are formed. So remember, this binding can be stopped by osteoprotegrins. So these osteoprotegrins will block this binding. Okay, whenever remodeling is not required, so excess remodeling नहीं होने के लिए क्या करेगा, osteoprotegrins. So these osteoprotegrins are basically secreted by your osteoblast cells. Okay, so basically, as I said, osteoblast cells will be forming your osteoprotegrins. Okay, so basically here these are the osteoprogenitor cells. Now before going to the bone disorder, what you need to know, about the regulation of bone metabolism. Okay, so basically this is the parathyroid hormone. This parathyroid hormone will release parathyroid hormone, and it will have effect on 3 organs, that is kidney, bone and GI. Okay, so kidney and bone it will affect directly, and GI it will be affecting indirectly. Okay, GI tract it will be affecting indirectly. So what does parathyroid hormone does? So parathyroid basically is activated whenever there is the calcium levels are decreasing. Okay, whenever there is calcium level are decreasing, there will be increase in parathyroid hormone. So okay, secondary cause I am saying. So PTH hormone, what it will do, it will basically act on the bone, and hence it will increase the calcium. How it will increase? So basically it will increase calcium and phosphate release. Okay, similarly this PTH hormone from the parathyroid gland will act on the kidney. Okay, and it will increase calcium reabsorption, and also it will increase the phosphate. It will increase phosphate. Okay, so increase excretion of phosphate. Similarly this kidney, what it will do, it will release 125 hydroxy vitamin D, and this 125 will act on the intestine, and it will also increase calcium absorption and potassium phosphate absorption. Okay, so this is the way how this mechanism, parathyroid hormone will act on bone, it will act on kidney, and it will act on GIT tract. Okay, and hence this will increase calcium. Okay, it will increase calcium. So basically what you need to know now is so this is about 125 hydroxy vitamin D. So this 125 hydroxy vitamin D, which is basically stimulated by parathyroid hormone, and this 125 hydroxy vitamin D is increased, and this also vitamin D will also act where it will act on muscles, it will act on intestine, it will act on bone. So in bone it will bone reabsorption will occur, and hence there will be increase in serum calcium and phosphate. Okay, from inside intestine also it will do same thing. So this is about the vitamin D. Okay, now so this figure again will explain you about fibroblast growth factor 23. That is very, very important. So here what happened, this is your phosphate. Okay, so whenever there is this phosphate, so phosphate will high phosphate, whenever there is increased phosphate, what happens, increased phosphate will basically increase your fibroblast growth factor 23. Similarly increased phosphate will also increase your parathyroid hormone. Okay, so remember, phosphate will, what it will do, phosphate will enhance PTH production by post transcriptional stabilization of, so phosphate basically will enhance PTH production. Okay, phosphate enhances PTH production, remember that. Now secondly what happened, PTH, this PTH, what it does, it basically will enhance FGFR. Okay, but PTH in return, what does it do, it will inhibit the, or basically reduce the serum phosphate by decreasing type 2A and 2C sodium phosphate co-transport. Okay, so basically if you remember this, it's good for your physiology, but what you need to remember is high phosphate will basically stimulate PTH will have a negative feedback mechanism and will reduce phosphate. Okay, that you need to remember from this one diagram. Okay, now remember this side. So 125 hydroxyl increases intestinal transcellular phosphate absorption by enhancing. So what this 125 will doing, 125 will also increase phosphate. It will increase phosphate, and phosphate in return will decrease this 125 hydroxy vitamin D. Okay, now coming to FGFR. So FG23 will suppress expression of type 2A2C sodium phosphate co-transport inhibitor VTC and phosphate reabsorption. So see, FGFR, it will be decreasing phosphate, it will be decreasing the phosphate phosphate. Okay, so this FGFR, what it do, it also decreases 125 hydroxy, and when 125 hydroxy decreases, it will be basically again this 125 hydroxy will decrease, then again phosphate will decrease. Okay, and hence, so this and 125 hydroxy, if it increases, it will stimulate FGFR3, and this FGFR3 will again decrease phosphate. So this is basically complete phenomenon which you need to remember in case when you are talking about phosphate and FGFR3, parathyroid and role of vitamin D3. So this basically explain this figure. इस फिगर को कुछ टाइम दो, आप बहुत अच्छी तरह से समझ जाओगे कि you are basically, you will understand complete role of phosphate, parathyroid hormone, 125 hydroxy, vitamin D3 and FGF23. Okay, so this figure explains beautifully. So again this is a simple figure. So at the parathyroid gland, so what happens whenever there is decrease in calcium or increase in phosphate, parathyroid hormone releases. Okay, and remember FGFR3 at the level of parathyroid will decrease parathyroid hormone. In the bone what happens whenever there is increase in phosphate or increase in vitamin D3, there will be release of FGFR23. Okay, and parathyroid action, because of parathyroid in bones what happens, there will be increase of calcium release, increase phosphate release and increase FGFR synthesis. In the kidney, what does parathyroid do? Parathyroid in the kidney will increase vitamin D3, increase calcium reabsorption, increase phosphate excretion, and obviously in the kidney what does FGF23 do? FGF23 will decrease 125 hydroxy, increase calcium reabsorption and increase phosphate excretion. Okay, then in kidney basically whenever there is low calcium, low phosphate and increased parathyroid hormone, there will be increased synthesis of vitamin D3. Okay, similarly in intestine, it is a vitamin D3 which is acting, which will increase calcium reabsorption and increase phosphate reabsorption. Okay, that you need to remember. So now whenever there is, so kidney failure, when we talk about renal osteodystrophy, so whenever there is kidney failure, what happens, there will be a decrease in GFR. This decrease in GFR will decrease phosphate excretion, and whenever there is phosphate excretion, decrease in phosphate excretion, there will be increase in phosphate, serum phosphate, and this increase in serum phosphate will result into metastatic calcification. Okay, because whenever there is increase in phosphate, okay, now we know very well there will be increase in phosphate that will result into increase in calcium. Okay, similarly kidney failure will result into decreased activation of vitamin D, and hence vitamin D when it is not activated, what will be, there will be impaired calcium absorption from the gut, and hence that will be decrease in calcium. So this decrease in calcium will activate parathyroid hormone, and this activation of parathyroid hormone or hyperparathyroidism or secondary hyperparathyroidism will be resulting in osteitis fibrosa. So this is osteitis fibrosa is type of renal osteodystrophy. Then increased parathyroid, what it will do, it will also result in bone demineralization, because obviously parathyroid hormone will result in reabsorption of the bone, and hence there will be occurring osteomalacia. Similarly, bone mineralization will result into increase in calcium and increase in serum phosphate, that will result into metastatic calcification. So these are the most important finding which you see in renal osteodystrophy. Okay, so this is osteitis fibrosa, related osteitis fibrosa X-ray. Okay, in hyperparathyroidism related bone diseases. Now coming to the so we have talked about this bone osteomalacia also. Okay, then so you can see this also again. So similar, there will be whenever there is a decreased renal function, by now we know very well that there can be hyperphosphatemia. There will be decreased 125 hydroxy and vitamin D3. There will be aluminium toxicity. This basically occurs in case of dialysis, and there will be accumulation of beta 2 microglobulin, which we have already learned in that there will be in case of CKD. Now whenever there is accumulation of beta 2 microglobulin, that will be resulting in dialysis related amyloidosis. Aluminium toxicity again can result into osteomalacia. Similarly, vitamin D3, we have talked about how vitamin D3 decrease will cause osteomalacia. Similarly, this vitamin D3 and hyperphosphatemia both will decrease ionized calcium, and hence they will cause hyperparathyroidism. This hyperparathyroidism will cause osteitis fibrosa cystica, and this is known as high turnover bone disease. We will talk about renal osteodystrophy, which can be high turnover bone disease, low turnover bone disease. Okay, we'll talk about that. So with coming आपको उसी का नॉलेज देने के लिए वी आर कमिंग टू दिस. So basically, when there is hyperparathyroidism, PTH is high, obviously the turnover of the bone will be high then, okay, that you need to know. And whenever there is decreased vitamin D3, obviously there will be osteomalacia, because there will be more reabsorption of the bone from because calcium, okay. Now remember, hyperphosphatemia, it can also, there is decreased expression of calcium sensing receptors that will result into hyperphosphatemia, and this will result into hyperplasia of parathyroid gland, which again result into hyperparathyroidism. Now one thing is remembering, so because whenever there is renal dysfunction decrease, you can have another disease, that is adynamic bone disease. So adynamic bone disease can also occur. This adynamic bone disease basically will result, and even this hyperparathyroidism, they will result into vascular calcification. So vascular calcification is again a very important finding in case of decreased renal function. So how this is occurring? This is occurring with this phenomenon. So now we come towards low turnover. So in the bone there will be low turnover, normal turnover, and high turnover, okay. Then obviously there will be low volume, bone volume, normal bone volume. So when you talk about bone, so bone, either there will be turnover in the bone or there will be volume of the bone, okay. So whenever there is volume, so osteoporosis and osteosclerosis, they are related with volume of bone, okay. These diseases are related with volume of the bone. If there is low bone volume, it is osteoporosis. If there is high bone volume, it is called osteosclerosis. But if there are low turnover, if turnover is low, then then the disease causes osteomalacia, okay, because turnover is low, okay, mineralization is low, okay. And if there is high turnover, then it will be osteitis fibrosa, okay, high turnover, osteitis fibrosa. And in adynamic bone disease, there will be low turnover, but mineralization will be normal, okay, mineralization will be normal, okay. But in case of osteomalacia, there will be low turnover, when mineralization will be abnormal, okay, mineralization will be abnormal. Here there will be low turnover, but mineralization will be normal. So this way you classify your kidney renal osteodystrophy as low turnover, high turnover diseases, okay. So this is cause of vascular calcification. So how vascular calcification is occurring? Because of increase in parathyroid hormone, basically there will be increase in phosphate and calcium, and obviously because in the kidney there will be retention of phosphate and basically retention of clotho, decrease in clotho, okay, and 1-alpha hydroxide, okay. So this will result into increase in phosphate, and this increase in phosphate and calcium will result into calcified vessels, okay. So this way we can classify renal osteodystrophy as high turnover disease, low turnover disease, and mixed uremic osteodystrophy, okay. So in high turnover disease, there is basically abnormal and increased bone remodeling and normal mineralization, like which we said about osteitis fibrosa. In low turnover disease, where there is decreased bone formation, there is normal mineralization, adynamic bone disease, or abnormal mineralization, there is osteomalacia, that I have said in that figure, okay. So here with normal mineralization, it is basically adynamic bone disease, and with abnormal mineralization, it is osteomalacia. Low turnover, high turnover disease, it is osteitis fibrosa with normal mineralization, okay. And mixed will be your low turnover and high turnover, or high turnover or low turnover, that can be your mix, okay. So high turnover renal dystrophy, so this basically we have talked about this, we have done about this in this figure also, so I'm not again explaining again and again, same thing, okay. So now there will be so again see this pathophysiology of CKD, mineral bone disease. So here with this there is high turnover state and low turnover state. Okay, so in high turnover state, what happen, there will be decreased GFR and decrease in renal mass. Okay, decreased GFR and decreased renal mass, this will result in decreased free calcium and phosphate retention. Okay, so this will obviously, whenever there is phosphate retention, this also result into more decreased calcium. Okay, so more decrease in the calcium. Now phosphate retention, what it will do, it will decrease calcitron, it will increase FGF23, and it will increase PTH. Okay, expression. Now this expression of PTH, what it will do, it will increase PTH. So increase in PTH will increase bone turnover and increase bone reabsorption, and hence there will be osteitis fibrosa cystica, and obviously there will be vascular calcification also, because obviously PTH increase will now start increasing calcium. Okay, and this side PTH oversuppression due to calcium based phosphate binders. So when you are using calcium based phosphate binder, then there will be decreased turnover and they will cause adynamic bone disease. Okay, and obviously some of the albumin deposition in bone, vitamin D deficiency, decreased bone turnover, this will result in increased mineralization lag time, that will cause osteomalacia. Okay, so these are the important things you need to know about renal osteodystrophy disease in case of basically in complication of renal diseases. Okay, now coming to the gastrointestinal and nutritional abnormality. So here you will see uremic fetor. So uremic fetor is nothing but it is a urine like odor, a urine like breath. Okay, when you breathe, you are getting urine like breath, with basically which is coming out because of breakdown of urea to ammonia in the saliva, and is basically associated with metallic taste, that is dysgeusia. Okay, so remember metallic taste can be seen in case of CKD. Okay, metallic taste in case of breath. Okay, then others are gastritis, peptic ulcer, mucosal ulceration, this all can be seen, then which can be associated with abdominal pain, nausea, vomiting, and GI bleeding. Okay, so these patients are, remember, prone to constipation when you are giving calcium and iron supplement. Then there can be endocrine abnormalities. So endocrine abnormalities, see, glucose metabolism is impaired in CKD, but remember fasting glucose is usually normal, or which is only slightly elevated. It is basically the PP glucose which is deranged little bit. Okay, and plasma level of insulin, basically it is slightly or moderately elevated in uremic patient in case of both fasting and basically PP. Okay, remember kidney, it helps insulin removal, but whenever there is CKD, now insulin can't be removed. So when you are giving therapy or when you are giving insulin, so you should give judiciously, and hence insulin dose is also reduced in case of CKD because of this funda only. Okay, so patient on insulin therapy may need progressive reduction in the dose because their renal function is worsening. Remember, metformin and sulfonylurea, they are contraindicated if GFR is less than half of the normal. Okay, so now there is a new drugs, or there are drugs which inhibit sodium glucose transport, and those drugs which inhibit sodium glucose transport in the PCT, they are helpful in reducing glucose. Same time, they are also helpful in maintaining kidney function, and also cardiovascular events also are decreased. Okay, so that you need to remember. Endocrine, so what happen in endocrine? Estrogen levels, they are low in the female, and okay, and there will be menstrual abnormalities like infertility, inability to carry pregnancy to the term are very much common. So when GFR is less than 40 in case of pregnancy, there is high rate of spontaneous abortion, and with 20% pregnancy only go towards live birth. Okay, in case of male, there will be reduction in the plasma testosterone level, and obviously sexual dysfunction and oligospermia may supervene, and sexual maturation may be delayed or impaired in adolescent children with CKD, even with those who are treated with dialysis. Remember, most of these conditions, that is estrogen level low से ठीक जगह पे आना, testosterone level ठीक होना, they occur when dialysis is, they will be treated when dialysis is done. Okay, so most of the complications are treated when dialysis is done. Now coming to the dermatological abnormalities. So pruritus is quite common and one of the most important or waxing manifestation of uremic state. Okay, and there can be also deposition of retained pigmented metabolites or urochromes, and then hence this can be logged as pigmented skin can be seen. Okay, pigmented skin can be seen. But very important finding in case of dermatopathy is nephrogenic fibrosing dermatopathy. So this is nephrogenic fibrosing dermatopathy. What it consists of progressive subcutaneous induration, especially on the arms and the leg. It's seen rarely in the patient with CKD who have been exposed to. So it is very rare, but seen in the patients of CKD. Basically, when you are who are exposed to MRI agent gadolinium. Okay. So basically MRI uses in contrast agent gadolinium. So in case of, because of this use of gadolinium, there are chances that you can get nephrogenic fibrosing dermatopathy. So what to do? So what current recommendation is that those patients with CKD stage 3, that is GFR 30 to 59, if they should minimize exposure to gadolinium, and those with CKD stage 4 and 5 should avoid the use of gadolinium agent unless medically necessary. But if you have emergency, you need to do, then what you do? You use gadolinium, but rapidly remove the gadolinium by hemodialysis after the process. So basically do hemodialysis after the process, though you are not doing any renal replacement therapy yet, but hemodialysis is necessary after using gadolinium. Okay, so this is the high yield point in case of this nephrogenic fibrosing dermatopathy. So now this comes with us that kidney function, basically if there is sodium imbalance, what happens? There will be sodium retention and overload. So what you can do sodium restriction and use diuretics. Potassium excretion, that is maintain kidney function, there is potassium excretion. If there is problem with this, there will be hyperkalemia, so you can do dietary restriction and avoid NSAID. Another complication is with acid excretion, which will result into metabolic acidosis, so just use sodium bicarbonate. So the problem with the bone, that is calcium phosphate valence, that is where if there is increased phosphate, increased parathyroidism, decreased serum calcium, decreased calcitriol, what you can do, you can give phosphate binders or you can give calcimimetics. Okay, and erythropoiesis, basically problem with is anemia, so you can give erythropoiesis stimulating agent or you can give iron replacement therapy. So these are basically the complications and treatment. So this in short, it describes the complications and treatment of CKD. Okay, so with this much information, we can basically stop today's topic. Okay, so this is again all about those what we have done, calcium. And so remember, calcium and MBD, so this is very very important. Renal osteodystrophy, again as I said, see, they can be bone turnover, so high bone turnover, mineralization. So if you remember by that figure, it will be very easy. Like osteosporosis will have high bone turnover but normal mineralization. Adynamic bone disease will have low bone turnover but normal mineralization. Osteomalacia will have low bone turnover but abnormal mineralization. And mixed uranic osteodystrophy will have high bone turnover but abnormal mineralization. That you need to know. Okay, vascular calcification, that is important. Okay, and so these all are some of the important things. And if I'll take these classes also. This class is basically so these are the phosphate binders, remember. So you can use phosphate binders like calcium based binders. So remember, so phosphate binders, you basically use calcium based binders. Okay, you don't use aluminum based binders, you use calcium based binders, which are better. Okay, calcium based binders are better than aluminum based binders. Okay, so these are some of the important things you need to know. So we'll talk about this all things, this treatment. When I talk about treatment of acute and chronic both together, I'll be teaching. So then I will talk about this treatment of this all other things also, and there we will include other things also. Okay, so basically slide is made already. Thank you very much, and we'll continue this class in next day. So tomorrow we'll do some MCQs based questions related to renal, and hope that will help to understand you this glomerulonephritis and tubular injury more better. Thank you very much, and see you in next class. Have a great time.